Everybody, and welcome to the John Wayne Cancer Institute Be Inspired series webinar on skin cancer and melanoma. This is the fifth John Wayne Cancer Institute webinar that we've done since the start of COVID, and we have a very interesting conversation today with three renowned experts in the field. You'll see Dr. O'Day and Dr. Fischer on the screen right now. You don't see Dr. Essner. He's in the operating room, but he will be with us shortly. He swears he will be with us shortly. So before we get started today, I wanted to let you know that this call is being recorded. And I also wanted to give you guidelines to make sure that you know how to ask the doctors questions after they speak. As you notice, everybody but the presenters are muted so that we'll be able to hear the doctors well. In order to ask questions, which we hope that you will do, you will need to type your questions in the chat function at the bottom of your screen. The chat function looks like a thought bubble, and it's located at the bottom of the screen. I will see your questions when you type them in, and I will ask the physicians the questions. Each doctor will take questions after they speak, and we will also take questions at the end of the talk. Hopefully, we'll be able to get through everybody's questions. If we don't get to your question, I will follow up with you in an email. You can send me an email to just respond to any of the emails that have been sent to you, and that question will get to me, or I'll see your question on the side of the chat, and I'll make sure to send that answer out. We have a very informative hour in front of us. We'll briefly hear about the John Wayne Cancer Institute's and St. John Health Center's general work in cancer treatment and research, and our vision for the future. We will hear how the Cancer Center pivoted to support research and treatment during the COVID crisis, which is still ongoing. And we will do a deep dive into John Wayne Cancer Institute's cutaneous oncology and melanoma program, one of the top programs of its type in the world. This program is led by world-class physicians and researchers and has a long history of work in melanoma care and research. The focus on melanoma extends to our surgical oncology fellowship program, where potential fellows are drawn to the John Wayne Fellowship to learn more about caring for skin cancers and melanoma. You've received information on our speakers, so I will do a short introduction. Our first speaker today is Dr. Trevan O'Day. He's the Executive Director of the John Wayne Cancer Institute and a medical oncologist who is one of the preeminent melanoma specialists in the world. John Wayne Cancer Institute has been a worldwide leader in the research into the immune system, and Dr. O'Day led the seminal research project on immuno-oncology that revolutionized the treatment of melanoma. He and his research teams have been looking into how the work in melanoma translates to other solid tumors using the immune system to fight cancer. Dr. O'Day?
Thank you, Gene. Thank everyone who's attending, both our trustees, our friends who have supported us, and our patients who have entrusted us with their care. This is really an extraordinary time, and I'm so proud that we've done a few of these, but my heart is with my melanoma and cutaneous skin cancer colleagues. Dr. Fischer and Dr. Essner are surgical oncologists, and we work very closely as a team, both on the clinical side and the research side. So this is actually a delight today to do that. We have, as I've said before, we have used our cancer research team to pivot to help the COVID research and clinical care. Dr. Fischer and I have been intimately involved with that, and it's been an extraordinary 9 months of collaboration and success in the clinic in terms of the management of COVID patients. So thank you all who have supported that, and that's for another topic. But what I really want to talk about today is this world-class melanoma program. I was recruited almost a little over 26 years ago. I know that because my son was born today at St. John's 26 years ago, and I had just arrived from Boston a month into our stay here when he was born. And I was brought in to join a world-class melanoma team with Dr. Morton, who had left UCLA in 1991 and come to a community hospital. Everyone said it wouldn't work, that the grants, the fellowship, the world-class doctors couldn't survive a transfer from the ivory towers of academia to a small community hospital on the West Side. Well, I guess 26 years, and not only are we here, we're thriving, and we have a presence on the world stage in melanoma that is really extraordinary for the size institute we are. We really owe that legacy to Dr. Morton and some of his early surgical techniques on what's called sentinel lymph node in melanoma that you hear about today. It transformed not only the staging of melanoma, but many other cancers. He was also a pioneer in immunotherapy with using BCG, a tuberculosis vaccine, directly into melanoma tumors, and he saw regressions. He tried to develop a vaccine in the early days of vaccines that ultimately failed, but had a international phase 3 trial that we led. I was fortunate enough to be involved in, I think, what would now be called the next major revolution in cancer care with a drug called ipilimumab. This is a T-cell antibody that I was fortunate enough to put in the first few patients with melanoma with a team of doctors in 2000. That's 20 years ago. 10 years ago, we presented this earth-shattering data at ASCO, the plenary session of ASCO, the most highly prized presentation, showing a 1 in 4 patients with melanoma were cured with just 4 doses of this very powerful antibody that attacks T cells. And since that day, 10 years ago, the field truly has been what we would call revolutionized with what we call these T-cell antibodies, or otherwise known as checkpoint inhibitors. And so let me just spend a few minutes on how they work and how they've changed cancer. You know, the 2 major areas of cancer success in the last 20 years have been the genetic understanding of the disease, the actual tumors itself, and targeting genetic mutations. And that's wonderful and has been a huge success. The other, probably bigger success has been using the immune system to actually not directly attack the cancer, but through its T cells, be able to activate these T cells and then send them to battle. And they are incredibly efficient at eradicating melanoma. So let me just give you an example. One of those drugs, ipilimumab, was a drug called a CTLA4 inhibitor, and this is a very important protein on the surface of T cells that normally puts them to sleep, but by blocking this protein, we keep these T cells activated and actually build an army of T cells, fresh adolescent T cells, and send them to battle. The other drug that came shortly after that was another T cell antibody. This is called PD-1 inhibitor. And it turns out that once T cells get activated and then in their adolescent phase, they go out and try to get rid of cancer. But sometimes they get tired and they become middle-aged, exhausted T cells. And so this other protein comes to the surface called PD-1, which is representative of the middle-aged, exhausted T cell. And so we have an antibody now that blocks that exhausted marker and brings middle-aged T cells back to adolescent state. And when we've combined the 2 together in melanoma, both a CTLA4 inhibitor and a PD-1 inhibitor, so we're not only bringing new, fresh troops, adolescent T cells into the battle that were never there, but we're also resurrecting these exhausted middle-aged T cells. The combination is synergistic and has led now to curing more than 50% of patients with widespread melanoma. So let me just put this in perspective. Historically, melanoma, when I came out of fellowship in 1994 from Dana-Farber in Boston, my mentor there knew Don Morton, and he said, you know, you've been doing leukemia and lymphoma, because I was a leukemia and lymphoma specialist. And he said, you're interested in immunology, melanoma is wide open. You need to go out to Santa Monica. Don Morton will teach you everything you need to know about melanoma, and then you come back and we'll set up a program, because melanoma is the worst cancer of all. In fact, he said it gives cancer a bad name. Well, that was 26 years ago. And I came out here, Dr. Morton was truly an inspiring mentor. I've never left, and I've been immensely involved in the field. But what I want to explain is that at the time that I came, and really those first 10 or 15 years, the average age of melanoma is about 50. This is 2 decades before most other major tumors. And it's devastating because the median average survival for stage 4, meaning when melanoma has metastasized out into the organs, was 6 months. And the 5-year survival was essentially 0. And so think about the other major cancers: breast, colon, prostate, lung. Average age is 60, 70, 80. Here you have 50-year-olds on average and younger that have, once it metastasized, a 6-month prognosis and a 5-year prognosis of almost 0. Today, in 2020, with the use of both 2 of these T-cell antibodies, but also we have targeted treatments to a genetic mutation called BRAF. With the combination of these drugs now, more than half are cured well beyond 5 years. And the average survival is about 4 years. So think about from 6 months to 4 years, and from 0 5-year survivors to 50 to 60%. That's just in 10 years of treatment. So that's where the science, the clinical trials that we've been involved with, these are New England Journal trials that have changed not only melanoma, but these combinations of CTLA-4 and PD-1, these combination T-cell antibodies now are approved for kidney cancer, lung cancer, liver cancer, mesothelioma, and soon to be cervical cancer. So the platform, which is really important to understand, is that when you activate adolescent T cells and you reinvigorate exhausted middle-aged T cells, it's not so dependent on the cancer. The cancer does matter to some extent, but you're really resurrecting the immune system. And as we know, the immune system normally keeps us safe from cancer. But as we age, our immune system weakens, and that's why we're more susceptible to cancers as we age. But really, these 2 new T-cell antibodies have changed the landscape, not only for melanoma. And I've been very involved with our John Wayne team, spreading the word and giving input across our other disciplines: breast cancer, lung cancer, GI cancers, and all of these cancers are looking to the sort of melanoma leadership and experience we've had to help direct them. Now, each cancer has its own other therapies. For example, in melanoma, we have these BRAF drugs that target a very specific mutation. Lung cancer has other mutational targets, and each disease will have them. So we do need each of our disease teams to sort of work closely together with knowing their disease and then integrating these immune treatments. So, and at the John Wayne Cancer Institute, we have world-class teams right now today in melanoma, GU cancers, that's prostate, bladder, kidney cancer, and then brain tumors. We're rapidly developing further breast and GI cancers, and that's really more to come as we go forward. So I just want to say that my other colleagues are going to talk about some of the other major breakthroughs, but clinical trials have been at the forefront of our success, figuring out which trials are critical to patient needs, opening these early trials, and allowing patients to help us answer really important questions. The other thing we've done as an institute is patients have by and large allowed us to use their tissues, their blood, their tumor, and collect that information as in their journey with their cancer. And we've been able then to monitor how they're doing. And this is really important. It's called a biorepository, where we can do translational bench science on understanding who's benefiting, who's not, and why that might not be the case. So our cutaneous oncology, and by that I mean all of skin cancers, is really a coordinated effort at patient care, clinical trial research, and biospecimen research. And the patients and the families are at the heart of that, but have really reaped the rewards. And I just think I have a couple minutes left, but I really want to, you're going to hear today from Dr. Fischer and Dr. Essner. Melanoma is a very small percent, only 4% of all skin cancers, but it's by far historically the most deadly, about 80% of the deaths. The most common skin cancers by far are squamous cell and basal cell cancers, and then a rarer cancer called Merkel cell. The reason I think this is important is we're evolving into a center of excellence, not only for melanoma, but for all of these other skin cancers. And the reason is all of these skin cancers have what we call a UV light signature. So because they all are related to excessive UV sunlight, they have a very common mutational profile that makes them very responsive to the immune system. And so the therapies that we use in melanoma now are highly applicable to squamous cell cancers and Merkel cell cancers, and just very recently in basal cell cancers. And you may not think they are not as deadly as melanoma, but locally advanced squamous cell cancers and basal cancers can be very disfiguring, cause a lot of unnecessary large surgeries. And so we're going to apply all of our hard work and integrated care in melanoma to be sure that patients with these other cancers can also be treated optimally. And this is a really fast-moving landscape, and we have a lot of clinical trials. So think of us as your skin cancer center of excellence, but obviously historically, melanoma has changed the world. And I'll just finish by saying, you know, in the early days, we would go to meetings and the melanoma group would be sort of, you know, it's a relatively small cancer in the scope of the big four. We would be put into the back rooms and, you know, we'd have our own little sub meetings and no one would talk to us because they thought it was an untreatable cancer. Now everyone comes to us to like, how do things work in melanoma? How can we apply that to other cancers? And it's because of this tremendous knowledge base, both in the immune system, but also our targeted mutational approach. So it's become sort of a poster boy for cancer, which is really quite a full circle from 26 years ago. So I'm just proud to be part of the legacy of this institute, the legacy of Don Morton. Rick Essner just joined us. Rick was one of the first fellows way back and actually predated me here when I came in '94. Trevan's the best and brightest of the future. He was a fellow with us. He has led he's helping to lead our fellowship program as well as our skin cancer. So we're bringing this legacy and knowledge to the next generation. So that's why I wanted to be sure we had both Trevan and Rick on the line. But again, thank you for all of your support as friends, with your financial donations, but more importantly, your willingness to stand with us, support us in any way you can. And for the patients and families out there that have entrusted your care to us, we are deeply grateful. It's been an honor, and we look forward to curing that next 50% of the melanoma patients. So 10 years from now, essentially all melanoma patients can be cured even with widespread disease. Thank you.
Thank you, Dr. O'Day. Very interesting as always. And welcome, Dr. Essner. It's nice to see you. So we do have a couple of questions. First one is, I'm a JWCI melanoma survivor, thanks to Dr. Essner, and I have a compromised immune system. Am I at greater risk for a return of melanoma and or other cancers? And that could be to any of you or Dr. O'Day. Well,
you know, compromised immune system, you know, is different. That's a complex topic. But what I would say is obviously having, you know, people with compromised immune systems have a higher incidence of melanoma. Thankfully, our treatments have been quite successful even in those patients. In fact, older patients, which is one sort of way that your immune system gets weaker, have actually benefited every bit as much, if not better, from these newer treatments. So yes, obviously having a compromised immune system puts you at risk, both for getting melanoma, for it to come back theoretically, but doesn't really prevent us from treating you effectively with the standard treatments. Okay. Another question. I donated my tissue from my, I'm going to say this incorrectly, probably lymphoscintigraphy 14 years ago. How long is this tissue viable? Oh, Rick, do you want to answer that one? You're still on mute, Rick.
Okay, there you go. So the tissue can be preserved for many, many years. There's just a number of different ways to preserve it, but the answer is we try to look ahead, and so we either freeze tissue in the tissue bank at John Wayne, or it's mounted in what we call paraffin, which is done through pathology. But the tissue can last for many, many years.
I think we have some of our tissue is more than 40 years old, some of the original tissues, yeah.
Okay, great. And one more question. Is there a genetic component to melanoma?
So that's a great question. You know, yes, not as, you know, breast and ovarian cancer is probably the most classic hereditary malignancy that we have. This whole area is evolving in different syndromes. So there is a hereditary syndrome that predisposes you to melanoma called P16, and it can be seen both in early onset melanomas and what's called atypical nevus syndrome, atypical moles. Sometimes this gene mutation can be associated with pancreatic cancer early onset. But it's a real small subgroup of overall melanoma. Almost all of melanoma is related to UV light as you age, and it's the exposure you get in your first 18 years of life that then sets you up with an incubation period of about 30 years on average, which is why the median age is about 50. And this is not a hereditary piece. This is directly due to environmental exposure.
Fantastic. All right, we're going to go on now to our second speaker, Dr. Trevan Fischer. Dr. Fischer is a surgical oncologist who is also the co-director of the Complex General Surgical Oncology Fellowship Program. He is currently building our program in Orange County, as well as directing it here in Santa Monica. And we're proud to say he was a JWCI fellow as well. Dr. Fischer.
Well, thank you for that introduction. Thank you to all the guests that are on the call today. We appreciate spending some time with us, learning a little bit more about what we do, and maybe a little bit about some of the things we don't talk about as often, as Dr. O'Day mentioned. As it was noted, I was a fellow here about 5 years ago, and I think it's important to sort of put into perspective, the really national reach that this institute has across not only the country and internationally. Growing, in surgical residency, you knew of the John Wayne Cancer Institute in Santa Monica because of the advances that were made by people like Dr. O'Day and Dr. Morton. It was one of the main reasons that I chose to come here for a very competitive fellowship program, and then was honored to be able to stay on and help run the fellowship program and train sort of our next generation of surgical oncologists and cancer surgeons. So as Dr. O'Day mentioned, we talk about melanoma a lot as it's, very in its early, before all these advances was very lethal. But there are actually more than 3 million skin cancers diagnosed each year, and the vast majority of those are basal cell cancers and squamous cell cancers. About 80% or so are basal cell cancers, and these tend to occur in chronic sun-exposed areas, so on the upper extremities and the head and neck. And like Dr. O'Day mentioned, these typically are more locally growing and don't have the risk to spread like melanoma and other cancers do, but depending on where they are, can be either disfiguring and difficult to manage surgically, or if left untreated, can spread to other parts of the body. About 80% of skin cancers are these, and that's probably an underestimation, because a lot of these cancers are taken care of by primary care physicians and dermatologists and don't get into some of the larger cancer registries. The next sort of most common skin cancer is squamous cell cancer, and although this is a little bit more aggressive than basal cell cancer, it's much less so than melanoma and some other skin cancers. This is a second picture there listed. These tend to be a little bit more kind of scaly and flaky. They have these crusted areas upon them, and mostly are also treated with just surgical excision alone, but they can at times spread depending on where they arise and some of the characteristics of them. I won't go into too much detail about melanoma, other than I think this picture, the third picture down, sort of really exemplifies the so-called ABCs of melanoma. So it's an asymmetric lesion with irregular borders and different colors in the lesion. So these are things that if you see, you should tell your doctor, have them evaluated most of the time with a biopsy. And that can be done in the clinic by either your primary care or dermatologist or a specialist like any of the three of us on the line. A much less common cancer, but one that's also very deadly if not caught early, is one called Merkel cell carcinoma, and so-called neuroendocrine cancers of the skin. And there's a lot of parallels to melanoma, and we use a lot of the therapies in melanoma for Merkel cell carcinoma as well. So there are many risk factors for skin cancers in general, and I sort of break them up when I talk about patients, how modifiable risk factors and those that are non-modifiable. So when we talk about skin cancers, it's no secret that UV exposure is the #1 sort of cause that can put one at risk for developing a skin cancer. Indoor tanning, as we have now learned from a few decades of this, has been sort of the #1 culprit of this, and we think that it's even probably underestimated how much the risk is for those who even one session is an indoor tanning puts one at a higher risk. There are some non-modifiable risk factors as well. Those are things you obviously can't control, and so your skin type, your hair color, your eye color, those are the things that if one has those risks, should be extra cautious when in the sun. And a family history or even a personal history of previous cancers and skin cancers put one at higher risk. When we talk about the treatment of some of the non-melanoma skin cancers, and I'll leave melanoma to, I think Dr. Essner is going to talk a little bit more about that. But as most cancers go, catching any cancer early gives one the best chance of a cure. And so most of the time, these skin cancers are dealt with surgeons. And so going in and doing a minor procedure, sometimes even in the office, or sometimes requiring an operation in the operating room to get the lesion out with negative margins is, for a lot of these non-melanoma skin cancers, the only treatment that you need. And then you go into a close surveillance pattern with close follow-up really for the rest of your life, as we want to catch these as early as possible. There are a few ways to reduce the risk and these modifiable risk factors. And so I try to review this with all of my patients, because it's very important, especially here in Southern California. Avoiding the sun between 10 and 4, that's when the UV rays are sort of the strongest. And I think that's when you should avoid spending time in the sun directly. And if you're going to be out in the sun, wear sun protective clothing and hats, and wide brim hats that cover the ears. As mentioned previously, never use tanning beds. They're just, the risk of developing skin cancers is just too high, and those should not be used. Using a daily broad spectrum antibiotic, about at least 30 SPF, and remembering to reapply. I think that's something that we sometimes forget when we're out and about. So if we put our daily sunscreen on, a couple hours go by, it needs to be reapplied. And patients often ask me what sunscreen to wear. What do I recommend? And I tell them that one that they will routinely wear is really the most important, as long as it's at least a 30, it's a broad spectrum in 30. So if a sunscreen that's going to set in your drawer and that I like that you won't put on doesn't really do anybody any good. So try them out, whether they're a spray or an oil or a cream. It's really important to put that on every day. And then something that I think is not really talked about a lot is seeing a dermatologist at least once a year, especially if you have any risk factors or family history or those fair complexion. Catching these early can make a big difference in how they're treated, and really seeing a dermatologist is important. I think some of the lessons we learned from melanoma, I think Dr. O'Day touched on this briefly, but with all the advances that we've made in melanoma, we're now using those sort of lessons to extrapolate to other skin cancers that, although aren't as deadly, can be a nuisance to deal with, can get so big that we need to do big surgery that can be disfiguring. And so we use some of the immune therapy medications. We have clinical trials here at the John Wayne Cancer Institute in our hospital that uses what we call intratumoral injections. And so we combine some of these immune therapy drugs with an actual injected substance that can synergize with the immune system drugs to have a better effect. And those sometimes treat the cancers to where surgery isn't even needed, which is always is a good thing. I will, just in the interest of time, I'm going to just transition just very briefly to the fellowship program. This is our last year's class of fellows. So we have a complex general surgical oncology fellowship program. There's 4 fellows a year with, it's a 2-year program. This has been going on for, since Dr. Morton came over from UCLA, and I think we're up to over 170 surgical oncologists throughout the United States. We also have a urologic oncology program that Dr. Wilson and Linehan Twardowski oversee, and a neurosurgical minimally invasive fellowship program with Dr. Kelly and the P&I group. So I think from a from a national standpoint, our fellows present oral presentations at all these meetings due to a lot of the support from our friends and patients like yourself. It's very important when they're looking for jobs to be out and being seen, and they this place really remains a very competitive and highly sought out training program because the legacy and the faculty that we have providing education ongoing. So I have no idea how much time I used, but I'll open it up for some questions.
Thank you. Thank you very much, Dr. Fischer. I have a few questions, and I'm just reading them real quickly. How, Dr. Fischer, how are individuals chosen for the JWCI fellowship program?
Yeah, so it's a great question. There's about 35 programs now. I think we were one of the first ones to get approval back in the early 90s. Most general surgery residents do a couple years of research in their general surgery program. So once you finish medical school, you go to a general surgery program. So all surgical oncologists are trained general surgeons, and then they specialize for 2 years. During those 2 years and throughout their general surgery residency, the residents do research, they try to find their interest. And so that, makes a competitive list. And to be honest, about, half of the people who apply for surgical oncology, if not a little bit more than that, are unsuccessful because it's so competitive still. And so we look for patients who obviously have good grades, good scores on their STEP scores, and have a track record of being an academician. So we want somebody who's going to continue that when they get here and continue that when they leave here. And so we want to have some tools that are already developed when they get here, and then we want to sort of hone those tools and create surgeons that do research, do clinical trials, do translational research, sort of have those opportunities as they move to their next phase in their career.
Great, thank you. Dr. Fischer, do you recommend one of your treatments instead of surgery as a primary treatment for an isolated basal cell carcinoma?
Most of the time, basal cell cancer is the first step in primary treatment is surgery. Sometimes, depending on exactly where it is, we may use some of these other therapies. Radiation, something I didn't mention, but sometimes radiation can be used in very sensitive areas to treat superficial skin cancers as well. And so, I take that point to really sort of focus on the fact that skin cancers, no matter how aggressive they can be, are really treated here. It's a multidisciplinary approach. The nice thing that we have is, our clinics we share clinics with the radiation doctors and the surgeons and geneticists, and all are sort of under one roof. And so when we have, difficult cases, we're able to very quickly collaborate with our colleagues and really determine what plan is best. And so I think sometimes you come to a surgeon and I recommend not surgery. That's okay. And so we share, our views on things and try to come up with the best plan.
Fantastic. Another question. I have had melanoma and have family members who've had squamous cell moles. When is a good time to start having my kids checked by a dermatologist?
That's another great question. Probably, once they, late teenagers, early 20s, I think is a reasonable time. And what I tell patients, if things aren't really changing, it may not be an every year thing. early on, but once you start finding things, or if you find things, then it's really important to sort of stay in track with once a year. But as far as I know, and Dr. Essner or Rodet pipe in here, but breast cancer, we know we start screening at a certain age. I don't know that there's really a standard age other than just, sort of everyone's a little bit different depending on their risk. But if you've got a family history, it's a good idea to have them checked out by a dermatologist routinely.
Okay. And one last question. I have a history of melanoma 4 times. Currently, I have almost 100 biopsies a year, with most coming back as basal and squamous. Would I be a candidate for any trial?
Well, probably, I don't know, Dr. O'Day, none of the ones that we have open right now. It would be interesting to look.
Yeah, go ahead.
I think it'd be interesting to sort of look at back at some of those and see, collect some of those tissues and see if we can find anything out as to why you have so many, looking at sort of the tumor markers and the genetics of those.
Okay. And I have a question for Dr. O'Day that came in that I didn't get to earlier. Dr. O'Day saved my life, and I'm eternally grateful for his support and the wonderful skilled staff at JWCI. What are the large, it moved. Sorry, I wrote it down. What are the large complications we are seeing from the immunotherapies?
Yeah, when you activate T cells in a very robust way, which is what we're doing, there can be serious and even life-threatening side effects. By and large, we've learned now over the course of 20 years, particularly at our center that has that deep experience, how to manage these. But basically, when T cells get really hyperactivated, that's a good thing when you're trying to eradicate the cancer, but it can cause inflammation at normal body tissues. And that's where, depending on the tissue, it can become life-threatening. But using steroids and reducing the immune system with steroids and other immunosuppressive agents usually will get things under control very readily. I think the most serious sites are really the colon, the liver, the lungs, and the heart, and very rarely the brain. And again, I think we're a lot better, but it's definitely, you're dealing with a very powerful group of drugs, and you have to have a lot of shared information between the patient and their family and our medical team so that we can optimize side effects. And if you do get severe side effects, it doesn't mean we can't control them. And in fact, those patients have done better long-term once we get rid of the side effects, because obviously those T cells that were causing inflammation were also likely eradicating the tumors. So it's all about being on it, being ready and prepared, and good communication between patient and medical team.
Thank you. And I do have a comment from the question about when to start having your kids checked by a dermatologist. One of the participants said, my daughter had her first AMH removed by Dr. Essner at age 7. In my humble opinion, if you have a family history, start the kids early. Okay. So with that, I'd like to introduce our last speaker, Dr. Richard Essner. Dr. Essner is the Director of Surgical Oncology and Co-Director of Melanoma and Cutaneous Oncology Research Program at John Wayne. He has a great history with the John Wayne Cancer Institute, being one of the first fellows here, and he's been practicing in Santa Monica and Los Angeles since that time. Take it away, Dr. Essner.
Thank you. Thank everybody for making it through this far. And I do appreciate everybody's valuable time. So what I'm going to talk about is a little bit about the science and kind of what we're doing here in research and understanding more about melanoma and certainly other skin cancers. So let me see if I can make this work. Okay, so as Dr. Fischer already showed you, these are kind of the common skin cancers that we see. And although these pictures are very graphic and clearly show differences between all these different skin cancers, the reality of it is that as patients and even as the dermatologists and us as surgeons, the skin cancers also, the images kind of blend together. And so what has been done of recent, I think probably many of you know, there's a number of different apps. So this is an example. Can you see it? It's on my phone. It's called Skin Cancer Detector. And what you can do is you can take a picture of your skin lesion and it'll try to tell you what it is. And the problem with it is that as you can see, again, all these images are nice and clear, but the reality of it is they somewhat blend together. And so this technology, we do everything on our phones now, but the reality of it, this is not ready for prime time. So we have patients ask us all the time, can we use these apps? And the answer is stay tuned, they're not quite ready. And again, it might be related somewhat to just the nature of skin lesions, background skin color, obviously a trauma to skin lesions, but perhaps they're coming. But again, get ready. So what we're doing in the research world is actually we're digitizing pathology. And so we've kind of skipped over the step as surgeons and scientists by taking a pathology. So this is a melanoma. I don't expect anybody here to understand, but this kind of darker area here. And what we do is we can have the pathologist scan the image, and then they create all these little pixels. And so the concept being is in the research world, we're trying to be able to identify a melanoma and perhaps even tell us more than just, yeah, this is melanoma. And so here's an example of, Dr. O'Day probably talked about different mutation types. And so the concept being is, can we actually tell more than just is this melanoma or not? Actually, can we tell what kind of melanoma and what is its potential risk of being a problem? So this is using modern technology. It actually uses AI to try to learn that you can tell the difference between these different types of melanoma. So this is, again, there's other groups doing this type of work, but we're trying to develop algorithms so that we can help the pathologists and gain more information about melanoma from the very beginning. So everybody in this conference, I hope, understands the sentinel node technology. So Dr. Morton has been credited for this 25 years ago, a really simple concept that you could actually inject a dye around a tumor. And so he did it in melanoma, it's done in breast, head and neck cancers, a variety of other cancers. But the concept being is that you could identify the draining lymph node. And at the time, this was a huge discovery because it allowed us as surgeons to pinpoint the lymph node that was at risk for having melanoma in this case. And we call the lymph node the sentinel node. And so there's probably a number of people on this call that have had a sentinel node removed. Well, there's more to it than just this lymph node as being connected, is that we've learned, number one, in melanoma, that this is where the melanoma, if it's metastasized, it's most likely to be first. So that's the first step. The second is, and it has since been proven, that you only have to take out the sentinel node if there's cancer in the sentinel node itself. So the idea being is we used to remove all the lymph nodes, and this evolved to now we take the sentinel node, and now even in 2020, that if your sentinel node has cancer in it, we don't remove the rest of the lymph nodes anymore. And so there's really a vast amount of work being done to understand why melanoma, other skin cancers, some degree breast cancer, actually localized to this first lymph node and seem not to spread to other lymph nodes. And in fact, if you take out the other lymph nodes, there may actually be a negative impact upon you. So we really evolved in the way we do surgery, certainly for early stage melanoma. So again, the technology is all developed here with concepts related to simple hypotheses. Can we identify where the melanoma is mostly drained from? Squamous cell carcinomas do this, like I said, breast and a number of other cancers. And so again, this technology. And so what we have moved forward, and certainly part of the rest of the world, is understanding, okay, number one is, can we predict? So again, we use algorithms, as we showed you with the slides. Can we take different scenarios related to the patients and their pathologies and give a patient an accurate prediction? And so this is a nomogram that we created. So what it does is you add up the points related to your age, your primary site melanoma. It's not very clear here, but this is head and neck, extremity trunk, how thick is your melanoma? Is there something called vascular invasion? And then you create a points, which will then give you a prediction. And so the idea being, we did this, and at the same time, there's actually an Australian group that did the work. And the concept of it is that can you actually, again, using artificial intelligence to build on the model so that we can actually individually predict the risk of you having melanoma in your lymph nodes, which would then tell us, okay, should we do the surgery or not? And then there's algorithms developed to say, what is your risk of subsequent spread, so that the patients can come talk to Dr. O'Day and have an educated view of what is their risk of having trouble and where does subsequent treatment fit in. And then on the other hand, how about if your sentinel node is negative? What is your risk of problems, and do we need to continue to follow you? And so this is some of the work that we're doing in our lab. And so what these little dots are, these are individual patients, and we collected their serum, but as the blood component, and we asked the question, could you actually tell the difference between patients that are going to recur? And so this is the group here, and these are people that don't recur. And you can see when we look at a certain component of the blood, we can actually tell the difference between patients that are going to recur with their melanoma and patients that don't. This work is very early on, so we're really excited about it, but we have to prove it so that we'll make sure that we're right, and there's a number of different ways to prove it, but based upon our initial work. So AUC suggests the accuracy of a test. So when we look at a test like, say, PSA or a mammogram to predict an outcome, we look at factors called sensitivity and specificity. And so this test, as it stands right now, the accuracy of it is almost as close to 100% as you can get. So this would be a marvelous tool if we can get it to work for prime time. These are actually blood samples drawn at the time of surgery, initial surgery. And so again, we're really excited about it. We haven't yet gone beyond the initial steps, but the concept being is, if we can prove it, this will be another tool in our armamentarium, because again, then we can tell Dr. O'Day, look, the chance of this patient recurring is so low, we don't need to treat them with modern therapies. Again, on the other hand, if we can predict which patients are going to have trouble, then should we get them started very early on in the treatment, perhaps at the time of when they just have their original biopsy. So again, some of the research we're doing and others, skipping, but so this is called a cluster analysis. So we have all these different terms. The other one's called a volcano plot. This is called a cluster. And what it does is basically, I'll stop touching the keyboard. The red is the overexpression. And so these are each individual tumors, and we can look at different genes. So on the left is a whole cluster of different genes. And we compared primary melanomas and metastatic melanomas, and you can see that they cluster in different places. So the idea being is, can you actually tell the difference? And this is not unique to work that's done at John Wayne, but what is unique is that we have this large repository of tissue that has been preserved. And somebody asked earlier, how long can you preserve things? And I suspect there's tissue in the freezer here, John Wayne, that's been frozen in liquid nitrogen for probably 40 years. And so we can go back to the repository and look at different tumors. And in more modern times, we can take the frozen tissue and not only look at the difference in genes, but we can actually now look at particular locations of the gene. So this is something we call bulk PCR, where we actually take the whole tumor and they look at all the different genes. And so we can compare the primary tumor and the metastatic tumors. And now there's newer technology that we can actually pinpoint areas in the tumor to try to tell very subtle differences. And this is quite remarkable in the world of science, to be able to pinpoint differences from location to location in a tumor. And so this is, we call these survival curves. And so what we're able to correlate is that people, for instance, in this particular study, that when they had metastatic melanoma and they had surgery, so this might be melanoma in the lung or liver, and they had the particular gene profile, their chances of success is much better than without it. And so again, these are all tools that we're trying to use to help identify which patients should have the therapies Dr. O'Day talks about. We know that surgery has a role, and so where should we fit the surgery in? Again, this 84 is 84% 5-year survival. How do we improve upon that? And on the other hand, how can we get patients that we would predict not to do well with surgery to push them up higher? So we have a ways to go in the world of melanoma, but our ability to discriminate patients from a good outcome and a bad outcome is really the science, and then fitting in the therapies at the appropriate time. So as a surgeon, I have to mention that the surgical world is also going under an evolution. And so this is the robot on the left that we have at St. John's. It's called Intuitive, but there's a number of different robotics. And so we can't get away with from the technology that makes surgery less invasive. It makes it obviously less traumatic, can make it quicker, can make it well-defined. Combining imaging with this robotic surgery allows us to pinpoint tumors better. And so we do believe there's certainly a role for surgery, but making surgery better is certainly one of our goals. And so these are just a number of different surgical companies that are out there with different products that are coming online very quickly in order to try to help us as surgeons, deal with the surgical problems in our diseases. And so I know that Dr. Fischer mentioned quickly about the fellowship program. And so I got this graph or this chart that basically shows this is kind of where all the different fellows that have been trained at John Wayne are located. And as he said, there's probably 170 that have been trained. So the dots are not exactly the number, but you can see the influence of the Institute has been all over the United States and world. And so we really had a profound impact on surgical oncology in the United States and abroad. And so we certainly appreciate all the support that we get in order that we can train these surgeons around the United States and world. And then finally, I'd just like to say, as we talk about skin cancer, try to be careful in the sun. I think everybody knows that. We all enjoy living in Southern California, but we just need to be careful in the sun. And then lastly, I want to say thank you to everybody that supports our program. When I looked at the list of people planning to attend this afternoon, it kind of is like a list of people that I've met throughout my life. So it's great that everybody can get on board, and certainly I'm happy to answer questions. Again, thank you so much for all your time today.
Thank you, Dr. Essner. Wow, those robots are so interesting, and it would be very interesting to watch you in action with that equipment. That's my personal perspective there. So I've got a number of questions for you. Do you still rely on lymphoscintigraphy, pre-melanoma surgical procedures?
Yeah, so we still do the sentinel node, and we do lymphoscintigraphy to help us find the lymph node. And so the answer is yes.
Okay, great. You said that better than I did. The next question, my melanoma looked like recurring pimple. After 6 months of watching it, the biopsy showed that it was on the surface, thought not to be a big deal. Not until it was operated on did we know it was almost second stage melanoma. Shouldn't we all be suspect of unusual growths?
Well, certainly for our melanoma patients, we follow them, and all three of us on this webinar spent a lot of time following our melanoma patients. And our biggest trial and tribulations is how exactly to do that. In other words, we examine people, we order imaging, we get a blood test on occasion, and how frequently we do it is really unknown. And so we really struggle with it. And that's why in our laboratory, we're working hard to try to develop a test who can predict. And other people in the Research Institute here are doing that, and even around the country, because the concept being is that, it's a huge use of resources. And wouldn't it be nice if we could figure out early on who's going to have a recurrence, like you're talking about this small recurrence versus somebody who won't recur at all.
Okay. Third question, are you using AI for predictability as well?
Well, the whole idea is so we created a model, and we don't have time to talk about it. We created a model first of predicting the sentinel node. That is, does it have cancer in it, yes or no? And so the second question was, can we predict who's going to recur? And so we took all the different features that we know that we typically use in clinical practice based upon features of their melanoma and the patient, and then we created a model, and so we predicted. And so others have done the same work, but in order for the AI model to continue to grow, you have to keep adding to it. So the answer is we added that to it. We're also going to add the blood test to it. We want to add the digital pathology to it. And so the concept being is we want to use different approaches. And again, there's other places around the country who have tried to create blood tests to predict recurrence in melanoma in particular. And the problem is, you probably need multiple different factors to be able to predict it accurately. And so that's why we think going at it multiple different approaches is probably the best.
Thank you. Dr. O'Day, could you speak about the collaborative work that you do, the cutaneous skin team does in the clinic, and why this is unique to St. John's and John Wayne?
Yeah, it's a great question. Thanks, Gene. I mean, this is sort of a passion of mine, and I've obviously worked in highly big time academic centers and private practices, and now this, what we call a hybrid academic model. I mean, I think you can certainly see the best in the world at any major academic center. The problem is that the way most academic centers are structured is their disciplines are not always, but frequently siloed, and the communication between doctors is certainly not optimal. Let's put it this way. I think what we're trying to accomplish in a very small space, and one of the values of being small but making a big impact, is that literally we're shoulder to shoulder. So when we have melanoma or skin clinic, I'm room to room with Trevan and Rick, and we have our set patients. Some of the patients are seeing both disciplines, surgery and melanoma, the same day every time, because they may be in a stage of their disease that really requires both of us to look at them. And then at other times, they may be handed off more to the surgeon or to the medical person. But the point is that if something, let's say that they're just seeing me, or they're just seeing Rick, or they're just seeing Trevan on that day, but something new has come up, or there's a complication, literally we just step out of one room and we jump in without an appointment. We basically are there to help the patient. We have tremendous fund of knowledge in our disciplines. And then this cross-fertilization, many of you maybe on the call who've actually witnessed this, we're not shy. We often will discuss what we're thinking in our heads right in front of you in the room. And obviously we're mindful of that to some extent, but you can see how we're trying to work together to solve problems. It's a tremendously powerful patient impact. And I believe in my heart, it delivers a level of care that is hard to beat anywhere in the world. Now, the key is you have to have motivated doctors who want to do this kind of integrated care across disciplines. And you have to have high-level, world-class docs. And that's not as easy in a smaller environment to recruit, but that's what we're doing. We have a legacy, and we're going to keep doing it because it gives the doctors satisfaction, and most importantly, it raises the level of care.
Thank you. For Dr. Fischer or Dr. Essner, for those of us who have been successfully treated at the cancer clinic, should we offer blood and tissue samples during follow-up appointments to benefit your research?
Well, I can answer it. Certainly, if you show up to the clinic, somebody is going to approach you. If you haven't already been included in the general research work, which allows us to gain access to the tissue that's been stored in pathology, and they'll ask you if you can donate blood. So the answer is yeah, it's greatly appreciated, because even if you had melanoma 10 years ago, we can learn from your blood either to predict if you're going to have another one or what happened with the first one. So it's all very valuable.
Yeah, and I want to echo that. You're doing a huge service to us as researchers. Hopefully you're helping yourself by participating in these trials, in active trials, but just your tissues and blood and being able to access how the clinical information anonymously, your name and identity is protected, but we can pair your clinical outcomes, how you're doing, whether you recur or not, with the tissue and the blood, and you're helping your fellow man and you're moving science forward. And it's a huge debt of gratitude we have to you. So thank you by agreeing to do that.
And one question for any one of you. We live in a sun belt, Dr. Fisher, you said wear your sunscreen every day. A lot of us are active in the sun all the time and wear sunscreen a lot. Are there any studies about chemicals in the sunscreen and how they affect you if you're using it a lot? And is that a concern?
I think so. There are no studies that show long-term side effects of negative side effects of wearing sunscreen. They do look at the absorption of that, how much of it gets into the bloodstream, and there are some data that supports that, but there's never been any data that I'm aware of that says that it's detrimental to your health. And as anything we do in life, there's always sort of a risk reward, pros and cons of it. So the risk of, or the reduction in your risk of skin cancer, maybe possibly deadly skin cancer, definitely outweigh any side effects that we may find out in the future. And so I think across the board through dermatologists and primary care doctors. And one thing I guess I didn't mention, and I always hear Dr. O'Day say it when we have patients together, is, when you're our age or older, the sun damage that causes sort of the skin lesions to come up happened a long time ago, teens and 20s. And so that's when we get most of our sun exposure. So it's really important for those of us who have kids or grandkids to really encourage good sun protective measures early in life. I think that's probably more important than even for us, later in life to use those protective measures.
Thank you. And there's a few more questions, but I'm going to respond to those on email afterward because it's 1:01 and I want to be respectful of all of our time. So I just want to say thank you very much to Dr. O'Day, Dr. Fisher, Dr. Essner for this incredibly informative talk, and to all of you for some great questions. I mean, it really helps us, to have these great questions and an interactive communication like we're having today. We have one more JWCI Be Inspired webinar this year. It's going to be on Tuesday, November 17th from 12 to 1 p.m. The topic will be on the genetics of prostate, colon, and pancreatic cancers, and will feature geneticist Dr. Ora Gordon, medical oncologist Dr. Twardowski and Dr. O'Day, and surgical oncologist Dr. Anton Bilchek. So if you're interested in joining that, please let us know. Just respond back to the emails that we've been sending you. And we hope to see you next month. Have a wonderful, yes.
Someone asked, I think Carol Marlowe, I just saw a chat box asking whether this would be made available. I think it is, this webcast, for friends and family who weren't able to hear it live.
Yes, absolutely. And I will be sending an email out to everybody with the link. Thank you for seeing that. I didn't see that, Dr. O'Day. Yeah, so Carol, yes, we will send that link out to you so that you can forward it to others.
Yeah, and Gene, if there's other questions that people have, how do they get the questions to us?
They can email us those questions. Just respond to any of the emails that we've sent to you, and I will get that information. We'll ask you the question, Dr. Essner, and then I will email back to the person who asked.
Okay.
Yeah. Okay, everybody, have a great rest of your day, and thank you so much for joining us. We appreciate it.
Thank you.
All right.
Bye-bye.